Okay, let's dive right into this. Welcome back, everyone. If you're ready to sharpen those clinical instincts, you are in exactly the right place today. We're actually going to be running a clinical shift simulation right here in this explainer. Our focus? Well, it's one of the most notoriously tricky presentations in all of emergency medicine, acute abdominal pain. We're going to take what is normally a really dense, highly structured diagnostic algorithm and translate it into intuitive, rapid-fire bedside action.
Doc, my stomach is killing me. I mean, we've all heard it, right? It's such a vague complaint, yet it's terrifyingly common. And the real challenge here is that this one single sentence could mean a 20-year-old with a mild case of gastroenteritis, or it could be a 70-year-old with a literally life-threatening ruptured aortic aneurysm. The second that patient rolls through the ED doors, the clock starts ticking. So our goal today is to give you a solid mental map so you can navigate all that uncertainty with absolute confidence and precision.
To tackle this, we are breaking things down into a really manageable sequence. 1. Triage. 2. The clinical assessment. 3. Imaging strategies. 4. Surgical emergencies. And 5. Disposition. All right, let's hit step 1. Triage, spotting red flags.
So the very first fork in our diagnostic pathway happens right away in the triage bay. We have to assess the ABCs and vitals to determine initial stabilization. On one side, you've got the hemodynamically unstable patient. Listen, here, we just don't have time to ponder. It requires immediate, aggressive resuscitation with IV fluids and oxygen, broad-spectrum antibiotics if you even suspect sepsis, and you need an urgent surgical consultation. But on the flip side, if the patient is stable, okay, we can take a breath and use a much more methodical, investigative approach. Let's look a bit closer at that unstable pathway first.
When a patient is unstable, you are actively hunting for these 4 terrifying killers. We're talking about the tearing back pain of a ruptured AAA, the classic pain out of proportion to exam that you see in mesenteric ischemia, the rigid, board-like abdomen of a perforated viscus, or a full-blown septic abdomen. If you suspect literally any of these, you're doing 3 things at once. You're resuscitating, you're considering a fast bedside ultrasound, and you are getting surgery on the phone immediately.
Moving on to Section 2. The bedside clinical assessment.
Now we get to slow down just a bit and play medical detective with our stable patients. Let's move to and see how this builds our clinical picture. Step 1 is, of course, your ABCs and vitals. Step 2 is the focused history, pinning down the onset, location, radiation, and critically asking about any recent surgeries or chance of pregnancy. Step 3 is your focused physical exam, and that's immediately followed by Step 4, which is pulling those essential initial labs. During that physical exam, your hands are absolutely your best diagnostic tool. And here's a quick bedside tip. Always, always start palpating away from the area of worst pain. What you're trying to do here is differentiate localized tenderness from diffuse tenderness. And most importantly, you need to stay on high alert for peritoneal signs. We're talking guarding, rigidity, and rebound tenderness. Because finding any of those, that dramatically shifts your suspicions straight toward a surgical emergency. Right alongside that physical exam, you're firing off the initial lab workup. You're going to need a CBC, CRP, electrolytes, BUN and creatinine, glucose, liver enzymes, and lipase. A urinalysis is also pretty standard here. But guys, the absolute golden rule, a beta-HCG pregnancy test is strictly required for all reproductive age females, no exceptions. You simply cannot afford to miss an ectopic pregnancy, and this one single lab test is your ultimate safety net.
Okay, Section 3. Smart imaging strategies.
So, we're heading over to radiology. Now, what's really interesting about this diagnostic algorithm is that it doesn't just suggest a lazy, blanket CT scan for everyone. That's bad medicine. Instead, it beautifully branches out based entirely on specific clinical scenarios. The whole pathway splits depending on where exactly the pain is and who the patient is. Let's break down a couple of these specific branches.
The crucial point here is tailoring the tool to the patient. So, say your exam shows right upper quadrant pain, and you suspect some sort of biliary disease, like cholecystitis. Well, your first line is going to be an ultrasound. If your patient is pregnant, your first line is also an ultrasound to strictly avoid any radiation. If that ends up being non-diagnostic, then you'd move to an MRI. But, and this is a big but, if the patient has vague, non-localized abdominal pain with absolutely no clear focus, then your primary imaging modality is going to be a CT of the abdomen and pelvis with IV contrast.
And you might be wondering why IV contrast for that CT scan. Well, it's because of this number right here, 100%.
According to our clinical protocol, IV contrast is absolutely essential because it provides 100% specificity for identifying segmental bowel infarction with reduced wall enhancement. When you're standing there dealing with vague, diffuse pain, that level of diagnostic certainty is exactly what you need to save your patient's life.
All right, hold up. Just as important as knowing what to order is knowing what not to order. It is time for a little myth-busting to keep you out of those common clinical traps that do nothing but waste time and resources.
The guidelines are crystal clear on this. Do not obtain plain abdominal or chest radiographs for acute abdominal pain. They offer practically zero diagnostic benefit in this specific setting. Furthermore, do not obtain upper GI series with small bowel follow-through or contrast enemas. They literally have no role when you are trying to rapidly diagnose acute abdominal pathology in the ED. Just skip them entirely.
And get this, here is another incredibly striking stat from the data. 11%. If a patient presents with both abdominal pain and diarrhea, getting a routine CT scan changes medical management in only 11% of cases. Right? So what's the takeaway? Use a highly selective approach. Don't let the scanner replace your own clinical judgment when the symptoms are pointing strongly toward just an uncomplicated gastroenteritis.
Let's move to Section 4, Diagnoses and Surgical Emergencies.
Okay, the imaging is back, and we have to interpret the data. If your workup reveals a perforation, mesenteric ischemia, a strangulated small bowel obstruction, appendicitis, or acute cholecystis, you have a surgical emergency on your hands. Medical management alone is just not going to cut it here. Urgent surgical consultation or direct intervention is absolutely mandatory.
And finally, Section 5, Disposition, Admit or Discharge.
We've reached the end of the shift, and for those patients who don't have a glaring surgical emergency, we have to make the hard calls on patient flow. You definitely want to admit patients who are elderly, immunocompromised, have sepsis, or have persistent vomiting. And hey, true diagnostic uncertainty is also a completely valid reason for admission. Conversely, a safe discharge is totally appropriate if the patient has stable vital signs, well-controlled pain, zero peritonitis, and, this is the big one, highly reliable follow-up with clear, written return precautions.
But before we clock out today, I want to leave you with this really provocative thought, which is a crucial caveat right from the bottom of our protocol. If an elderly patient or an immunocompromised patient presents with just mild, vague, nonspecific abdominal pain, will you still catch the serious disease hiding beneath? The source data explicitly warns us about this. Elderly patients have a vastly lower threshold for severe pathology. Their labs might look completely normal despite a life-threatening disease quietly brewing inside. So always keep your suspicion high, trust your clinical exam, and never let a stoic presentation fool you. Thanks so much for joining me on this shift, and I will see you in the next explainer.